Welcome, everyone. Welcome to this webinar, which features the Researching Families for Better Nutrition Common Approach and the research study 𝘚𝘏𝘮𝘬, which looked at comparing effectiveness and cost effectiveness of cash plus in prevention of acute malnutrition. I will start with some information on the logistics. Translation is accessible by clicking the icon on the bottom of your screen. We have only translation in French today. You will be able to follow as well some slides in French. Next slide, please. Today's webinar has kindly been organized by the Global Nutrition Cluster. And next slide, please. By the contribution of the Cash and Voucher Working Group under the Global Nutrition Cluster, which includes many agencies, but those that you see in the slide here are the most active members. And it has been possible just really by the support of the GNC team and the contribution of our generous donors. Next slide, please. So I'll just present myself. I'm Marina Tripaldi. I am a Cash and Voucher Technical Advisor for Save the Children International, and I am one of the co-chair of the CVA Working Group. I'm pleased to introduce this webinar today, which I think will bring an important piece of evidence to the ones that are already existing on the effectiveness of cash in prevention of malnutrition. We are gonna really, the objective of this webinar is to share with you the findings of our research study on how cash has been effective really in the prevention of malnutrition, and some sub-studies that were included in the trial. This project has been led by Johns Hopkins University in collaboration with Save the Children, and in particular Save the Children Somalia country office, and two local partners, the Ministry of Health and the National Bureau of Statistics. We are going to give a space as well for discussions on how we think these findings of the study will be useful for the audience and for some key stakeholders. Next slide, please. In terms of today's agenda, we're going to start with the presentation of the study findings, including the sub-studies on the analysis of drivers. We have a sub-study on wasting relapse and other information on the concordance method, which will be led by Johns Hopkins University. And we will also present the intervention model, so how this project was implemented on the cash and on the nutrition side. We will have a Q&A session, an interactive space in which we will look at the questions that have been posted. Yeah, that reminds me. Please, you're going to see you have a Q&A window in the Zoom bar that you can use to post your questions during the webinar. We are going to do our best to answer to these questions in the window. But we're going to use this space also if there are some live questions or if there are any comments from the audience that wants to share. We are going to close with some exchanges with stakeholders, key stakeholders, and we're going to hear from them how they think they're going to use the findings of this research for future programs and policies. Next slide, please. Here we have today's speakers and panelists. I have already introduced myself. I will co-facilitating this webinar with Shelley Walton, a Senior Research Associate from Johns Hopkins University, and also Research Co-Investigator. We will have our investigator, Nadia Axer, from Johns Hopkins University, which will guide us through the study findings. From the Somalia country office, Save the Children, we have 𝘏𝘶𝘮𝘢𝘳𝘪𝘢𝘯𝘓 our nutrition specialist, and 𝘏𝘏 Isaac, our child-sensitive social protection technical specialist. And to promote some messages in the panel, we also have Omer Meftu, our head of health and nutrition and WASH from Save the Children Somalia country office. We're going to discuss these findings as well with our local research partner, the Ministry of Health of Somalia. Dr. Osama Abdi Ali is the representative. And we're going to have the head of cash and voucher assistance, Nick Anderson, and Kate Golden, the senior nutrition advisor for Concern, also representative of our cash working group, to close the panel session with their messages more on the global side. Next slide, please. We're going to start with one poll question. Miriam, if you can help me to launch the poll. So we would like to hear from you. What's your perception? Do you believe that cash can be effective in the prevention of malnutrition? Yes, no, or you are not sure. You can choose one of the three options. You might have seen now the poll window coming up. So we're going to give it a minute for the audience to choose. Vote what you think is true. What is, in your experience, what do you know from the evidence? Can cash be effective in the prevention of malnutrition?
Marina, just to come in while people are answering the polls, as a reminder, the presentation is available in both English and in French. If you would like to switch languages for the presentation, please click on the appropriate tab, which is on the top of your screen on the left-hand side. You should see two tabs there, English translation and French presentation. So you can choose the language of the presentation. Thanks, everyone.
Thank you, Miriam. So I think we can now close the poll and see the answer. Oh, very interesting. So 81% of the audience think that cash can be effective in prevention of malnutrition, but we still have a good 20% between the no and not sure that we hope we are going to convince today with our presentation. So without wasting any other minute, I'm going to hand over to our primary investigator, Nadia Aksep, for the presentation of the research findings. Nadia, over to you.
Thank you, Marina, and good morning, afternoon, everyone. Thank you so much for joining, and thank you for taking the time to listen to our work on the 𝘏𝘶 trial in Somalia today. So I'm going to present for the next 30 minutes or so the series of primary and secondary studies that we did under this project. Next slide, please. But first, I'll start with some background on the Somalia malnutrition context. Next slide, please. So malnutrition in Somalia is a major concern. A recent IPC estimate proposed that just between January and June of this year, 1.7 million children under the age of 5 were estimated to experience acute malnutrition. You see the numbers stated there on the slide. About 466,000 children had SAM, or severe acute malnutrition, and over 1.2 million had moderate acute malnutrition, or MAM. More than 61% of this burden is concentrated among rural populations, including and about 23% in among internally displaced populations and 16% in urban settings. 3.4 million people, or about 17% of the population of the country, are in crisis mode or worse, according to the IPC Phase 3 classification or higher, just in January to March of 2025 of this year. And this is expected to continue. So I won't read through all the other stats here, but as you can see, there is a major crisis around malnutrition in Somalia, and this persists throughout the year and exacerbates during certain seasons, including during rainfall seasons where flooding can happen, also with regards to conflict and insecurity that can affect malnutrition, the market fluctuations and inflation, and various other factors and drivers that can affect these trajectories. Next slide, please. So in 2024 alone, 1.3 million people, or about 35 to 40% of the population in need in Somalia, received food security assistance. This included access to food and security, food security, water security, shelter, and better wash resources. However, due to funding shortages, the humanitarian assistance that supported this declined since March 2024. Typically, the first line of support of aid includes cash transfers. So, for example, more than 250,000 households in Somalia or expected to receive emergency cash aid from the World Bank in 2023 after a major flooding. So this is very typical when there is a crisis, acute crisis that happens for any of the reasons I mentioned earlier. There will be a program that happens that can support families through cash and sometimes food aid. Why cash? Cash has been found in the literature to promote dignity and autonomy. It allows the recipients to use the cash for what they deem is necessary and what they need most. And it also supports local markets. Next slide, please. So we know cash is used, and there's evidence out there to support that cash is effective. But there are many unanswered questions and evidence gaps when it comes to cash, particularly around the most effective, cost-effective, and acceptable approaches, and in humanitarian settings. The existing evidence primarily focuses on cash transfers and how they relate to food security outcomes, not necessarily whether or not cash transfers can improve nutritional outcomes. For Save the Children, most of this evidence comes from their Resources for Better Nutrition, RFB, and Common Approach, which typically provides cash and or voucher assistance with social and behavioral change communication as the core components, and maybe other interventions as well. But that program has been tested in development settings, and there is a need to test it in humanitarian settings. In summary, there are other gaps as well in the literature, but I'll just summarize here. There is a need for research around cash and voucher assistance duration. So studying which duration is sufficient. So for example, is 3 months sufficient when there's a crisis? Is 6 months? Is 9 months? Is 12 months? What is the right amount of time that is needed for the cash to be ongoing to support families? And what is the amount? In addition to that, what is the most cost-effective approach in terms of providing cash? Is it cash alone? Should cash be provided with the social and behavioral change communication or other interventions? But what is the right approach there that is both effective and cost-effective? And then also a need to generate this type of evidence in humanitarian settings. Next slide, please. To address these evidence gaps, our team worked with the partners that were named a little bit earlier in Somalia to conduct a cluster randomized trial to be able to answer the following study aims. So first, we were looking at comparing the child wasting, so children under 5's wasting status and the wasting status of their mothers across 3 arms within a programmatic setting. So where families were receiving cash alone as the control arm, cash plus SBCC as our intervention arm, one of the intervention arms, and then cash plus top-up amount of cash for pregnant and lactating women as another intervention arm. And we provided this for 3 months and 6 months. And we were aiming to look at and try to answer the question around duration and the intervention design to see which one yielded the most benefit. So that was one of the questions we sought out to answer here. Another question was around the cost effectiveness, of course, of that design. The third question was trying to understand determinants or drivers of the various family members and households that were receiving these benefits. The fourth question was to try to understand the concordance of MUAC and weight for height Z-score based methods for measuring child wasting. We know that MUAC is very often used programmatically and in the field to evaluate whether or not a child is wasted, but it may have its limitations. And so within the setting, we were trying to establish what is the measurement gap here, and how much underestimation or overestimation happens when we compare the different methods to be able to evaluate wasting. And the fifth question here was to look at the relapse, so understanding the rates and determinants of child waste and relapse within the setting, and we followed up children for 6 months. So I will try to present within the next 25 minutes or so some of the top level results. There's a lot more to share and a lot of analyses we've done, but in the interest of time, I'll try to give you some of the top line messages today. Next slide, please. First, a little bit on our design. So this was a cluster randomized trial. So we had villages that were in the setting in 2 regions, in Somalia, 𝘏𝘶𝘮𝘬 and 𝘓𝑗𝑚 regions, which are typically affected by a range of these crises that I mentioned that often result in food insecurity and malnutrition. And so the clusters were selected randomly within those regions, and then randomly assigned to one of 3 arms. And I will talk about the arms in a second in detail, but the first arm was the cash alone, second arm was the cash plus SBCC, and the third arm was cash plus a top-up. And then we followed up the families for 6 months, collecting data at enrollment, at midline, and also at endline. Next slide, please. So what were the interventions? Each participant received 1 mobile cash transfer per 6 months for 6 months, and the transfer amount was established using the minimum expenditure basket, MEB, which is a typical method that's used to evaluate how much a family actually needs in that particular setting or that region or that district that aligns with the minimum expenditure for that household. And so it may vary from region to region, just depending on how much these items cost and are accessible. So in arm 1, where we provided cash only, you can see the split there between the 2 regions. In 𝘏𝘶 region, the families were receiving the $90 cash transfer. In 𝘓𝑗𝑚 region, they're receiving a little bit less, $70 USD. In arm 2, same amounts were provided in addition to the SBCC. And then in arm 3, the same amounts plus $35 top up for the pregnant and lactating women in each of the regions. And you see the totals that were summed up from that distribution. In terms of the SBCC, what was provided, so later on in the session, we'll talk in a little bit more detail about the intervention itself, but I'll just summarize here. The SBCC that was provided covered topics such as breastfeeding within the first hour, so early initiation of breastfeeding, exclusive breastfeeding for 6 months, appropriate complementary feeding, appropriate hygiene practices, and physical and mental stimulation of the child, and nutrition of pregnant and lactating women. The sessions were led by a trained lead mother who facilitated the discussion with 10 to 15 mothers. They were held weekly over 12 weeks and about 45 to 60 minutes per session. This also provided a safe place for mothers to exchange ideas and share experiences and get to talk to one another about the various things that their household is experiencing and how they are engaging in this program. Next slide, please. With that, let me go ahead and get into some of these study results. Next slide, please. So I'll start with the primary outcome, which was focused around the child. Our trial was designed to look at the differences in child wasting prevalence between an incidence between the 3 arms. So this is, let me start with this first. Next slide, please. Okay, so I have the key message pop up at the same time. That's okay. So overall, we found that the key child characteristics, so a range of demographic and household characteristics that we looked at, did not vary over time or by arm, suggesting that our sample remained representative and comparable across arms. One exception to this is that there was a flood that happened partway through our trial, which affected about 15% of the sample. As is expected in humanitarian settings, you know, these crises can happen. And there was a differential in terms of which arms were affected there. But for the most part, all the factors that we studied and looked at were similar at baseline between across the arms, suggesting that there was good comparability and that the randomization worked. Overall, we found that arm 2, which was the CASH plus SBCC, appeared to have achieved the greatest and sustained benefit in reducing and preventing child wasting in both prevalence and incidence analysis. And this persisted in both when we stratified the analyses between the two regions. This persisted in both regions as well. So let me show you some of the analyses to support this conclusion. Next slide, please. Okay, so here's the analysis of child wasting. We use weight for height Z-score here to look at wasting, child wasting prevalence as an outcome for, you know, because it is sort of the best reference standard out there to be able to classify a child as wasted or not. And so this is what the figure looks like here. We have in the blue arm 1, in the red arm 2, and in the green arm 3. And so just looking at the figure, you can see that arm 2 dropped, you know, all 3 arms were about the same level of wasting prevalence at baseline, but then there was a drop in arm 2 that happened, which was statistically different from the other 2 arms. So a substantial drop that happened in wasting, and that sort of then plateaued by end line. And a similar pattern is seen in the other 2 arms, but the arm was not as great. Sorry, the drop was not as great in the other 2 arms. So just looking at this data, we can see that arm 2 really benefited the most in terms of preventing in terms of reducing child wasting prevalence. Next slide, please. When we tested these differences statistically, there's a lot of comparative analyses here, but overall we found that arm 2 was the one that was statistically different from arm 1 and arm 3, again, supporting the inference that it was the arm that was the most effective overall in reducing child wasting prevalence. Next slide, please. Yep, and this is just a summary of that. Next slide, please. Next slide. Or just click advance. Yes, great. Thank you. So this is the analysis of wasting incidence. We compared both because, of course, prevalence tells us about the current situation around wasting and incidence and tell us about the new cases of wasting. And so we wanted to look at both in combination to see which arm produced or had the most improvement. And overall, we found that arm 2 also had the greatest and sustained benefit, not only for wasting prevention, but also for child wasting incidence as well. Next slide, please. Okay, let's talk about the maternal outcomes. Now, our trial was not designed or powered to evaluate maternal malnutrition outcomes, but we did look at them descriptively. And here is a summary of what we found. So you see some points listed there, but overall, I think the key message here is that maternal wasting did not improve as much as the child wasting did, according to this exploratory analysis. However, arm 2, which was the CASH plus SBCC, appeared to have the better maternal wasting outcomes compared to the other 2 arms. So despite that they weren't, you know, statistically different across the arms, overall arm 2 had the lowest rates for maternal wasting. So I think that this supports that Arm 2 was benefiting both the mother and the child, even though we weren't able to establish it among the mother because of the design we had. There is a trend towards this intervention, which is CASH plus SBCC, appears to be benefiting the mother as well. Next slide, please. We also did a range of analyses to look at cost efficiency and cost effectiveness across the arms, both from a programmatic perspective, so the program itself being delivered, but also from a societal perspective. And, I don't have time today to present all the results, but I'll just let you know what the key message was. We found that in all the analyses that we did, Arm 2, which was CASH plus SBCC, was the most cost efficient and the most cost effective, despite the fact that there was an added intervention. The SBCC, the overall cost ended up being quite low compared to, for example, the added money or the top-up cash that was provided to Arm 3, relative to how much gain there was in child wasting, preventing child wasting. And so that yielded Arm 2 being the most cost effective, using both a programmatic and a societal lens. Next slide, please. Let me get into some of the drivers of wasting results across arms. So we did a series of analyses here where we broke up the sample into different subgroups. For example, Bay region versus Huron region, younger child under the age of 2 versus older child over the age of 2, and other subgroups as well, just to try to understand what were some of the factors that were influencing or correlates of child wasting and maternal wasting across these different subgroups. So I don't have time to present all those results today, but what we did find, kind of the summary message there, is that the factors that are linked to child wasting are heavily contextual. They do vary by subgroup and they do vary over time, which makes sense for something like wasting, which can fluctuate and change with seasons. But also the context, depending on whether it's an urban setting and has access to markets and so on, or whether it's a very young child versus an older child, those that kind of subgroup look can really influence what the top drivers end up being. Next slide, please. We also looked at comparing then drivers between arms, just because we wanted to understand further. Okay, so Arm 2 appears to be benefiting the most from the intervention, and they're getting CASH plus SBCC. So what were some of the factors that may have been contributing to those changes, and particularly when comparing to Arm 3, which was the arm that was actually receiving the most CASH out of all the arms. So we stratified the analysis here in line with the UNICEF malnutrition conceptual framework, where we looked at drivers at the immediate level, the underlying level, and at the basic level. And we looked at many, many drivers, but I will just show you a few today, which I think, kind of help us make the point of things that might have been contributing to the differences. So at the immediate level, so this is the most proximal level, we found that child diet diversity, which included the intake of animal source proteins, improved across all study arms. And Arm 3, interestingly, showed highest levels by end line. So you can see that, that in the red box there. So at baseline, all three of the arms appear to have the same amount or proportion with regards to children receiving animal source proteins. And then there is a change over time, and it appears to be higher in Arm 3 by the end line. So there is in Arm 3 a greater consumption of animal source proteins, which is interesting. With regards to the childhood illness, so this is looking at acute illness in the past 2 weeks, and you see the indicator listed there. Interestingly, this increased in Arm 3 from baseline to end line, so from about 26% to about 37%, whereas in the other arms it did decline. Next slide, please. We also looked at drivers across at the underlying level, and so there were some indicators here For food security, we looked at the food consumption score, the household hunger scale, and also the coping strategies index, reduced coping strategies index, RCSI. So I'll just show you quickly or summarize here for you what we found. We found that food security indicators, it basically improved in all arms except in arm 3, where the food consumption scores appeared to worsen overall. So food security did not appear to improve in arm 3. And this is sort of the main message here, but it did improve in the other 2 arms. In terms of vaccination coverage, we found that vaccine coverage increased across all 3 arms, and particularly with arm 2 achieving the highest rates by N line. So you see that highlighted in the box there. With regards to WASH, we found access to protected water sources improved and across all the arms. But with regards to open defecation practices, that persisted throughout, and we have an indicator included here where in arm 3 in particular, it appeared to worsen substantially compared to some of the other arms. And so I think that was, even though access to clean water sources improved across the arms, the open defecation practices didn't really improve that much across the arms and appeared to be the worst in arm 3. And then hand washing facilities became more available, but gains were limited in arm 3. You can see that it's sort of high throughout. Having no access to hand washing facilities was pretty much, really, really high, well above 80–90%. And there were limited gains in arm 3 over time. Okay, compared to the other arms. Next slide, please. We also looked at household expenditure patterns and other factors at the basic level, for example, such as women's empowerment, using a proxy of joint decision-making between husband and wife, or just women's decision-making or wife decision-making, and also a range of other indicators that I don't have time to get into today, but I did want to spend just a few moments looking at the expenditure patterns, just so we can see, what are people spending the money on? I think this is always an important one for cash programs. So we're providing cash. How are they spending that money? This is what the distribution looked like across the arms at baseline. So you can see it here. The majority of the money that was provided was being spent on food. That's in the dark blue. Some on better access to better hygiene services. And then we have money being spent on clean water, money being spent on access to maternal and child health services, clothes and other non-food items, and also education. So a similar kind of pattern across the arms at baseline. Now, if we move ahead, next slide, please. By midline, we can see the patterns are shifting. And then if we go to end line, this is kind of what it looks like. And I particularly want to compare arm 2 and arm 3, just because arm 3 is the one that received the most cash, and arm 2 had the greatest benefits to child wasting. So let's see how they're spending their money. And so you can see the distribution here in terms of expenditure on food is about the same, and similar expenditure on hygiene, a bit less spent on transportation services in arm 3 compared to arm 2. If we look at access to clean water, so arm 3 spending less on procuring clean water. Some of the other ones look the same here. Sorry, I'm getting a lot of pop-ups here. With regards to access to medical services, a little bit less spent by arm 3. With regards to expenditures on clothing and other non-food items, we can see arm 3 is spending more on clothes and other non-food items compared to arm 2. Arm 3 spending less on education compared to arm 2. And also a little bit more on agriculture, and arm 3 is also spending more on social activities. So there's some differences. When we break these down and look at them kind of statistically, you can see that there are statistically significant differences, but it's interesting to see in a figure like this that the patterns can be slightly different. And arm 3, which was getting the most cash, ends up sort of prioritizing some other things that are maybe not directly related to preventing malnutrition. And when that could be a function of the fact that they were not provided the SBCC information that they needed on how best to spend the resources. Next slide, please. Okay, we also did a series of data collection where we spoke to mothers and fathers who were across all the arms actually, but also who were particularly beneficiaries or benefiting from the SBCC component to try to understand what were their views and perspectives on the program, but also on a range of other basic, immediate, and underlying factors related to malnutrition. Here are some of the quotes that were provided. I don't have time to get into all the results today, but I just wanted to highlight and show a few to you today. So for example, one of the mothers said here in arm 2, the cash assistance has been covering some of our basic needs like water expenses, electricity, educational fees, food, and milk for the children. So that was a mother in Ḥiran region of arm 2. There was a father in Bay region that said, there's a lot that I can't afford, such as meat and milk because of the lack of money. Sorry, that's also from a mother in Bay region of arm 3. And then there was a husband in Bay region that said, we are in inflation, the road between Baydoa and Mogadishu, which is the main road that connects them to be able to access better markets, is cut off and there is not enough food for us. So this was happening at a time when there were floods happening in the area. Another quote here, the monies used to buy nutritious food for the children, such as bananas, eggs, and soft food, that will be a great help to them. That's from one of the mothers in arm 1. And then a message from a mother in arm 2 that received the SBCC. She says, eating a variety of foods is healthy. And so a lot of the perspectives and comments that we were able to analyze from the mothers and fathers in these groups really supported and helped us understand better what was happening across the arms and supported the main messages that, you know, the arm 2, which was receiving the SBCC package, really did improve people's knowledge and awareness of malnutrition at large and thereby influence their practices and their behaviors. And we did do a series of analyses looking at practices and behaviors and how those changed over time. I didn't have time to share them with you today, but we did see that in core areas like breastfeeding, complementary feeding, better wash practices, that there were improved practices over time, which ultimately resulted in some improved behaviors as well. Next slide, please. Next slide, please. Okay, let me get into the wasting measurement analyses that we did. Next slide, please. Here we were aiming to look at 3 measures or 3 ways of looking at wasting, which is MUAC, MUAC-Z, and also weight for height Z-score. So MUAC and MUAC-Z you may be familiar with. MUAC and weight for height Z-score you may be familiar with, but MUAC-Z may be new. MUAC-Z is an age and sex adjusted MUAC-Z score. So instead of using just a simple cutoff of MUAC to decide or classify a child as being wasted, MUAC-Z is age and sex adjusted instead. So we looked at these 3 common ways of evaluating wasting and compared them in terms of their concordance and agreement overall, but also stratified by the child age to understand whether or not children were being misclassified as wasted or not. And this was really important because there may be children who were not identified as being wasted using one of the methods who actually needed treatment. And we wanted to understand what that discrepancy was. We know this gap exists in the literature. There is some evidence to support that MUAC-based assessments alone are insufficient and will underestimate the true burden of wasting. But we did want to be able to establish this in this setting as well, as it was relevant to programming and thinking about sort of policy in this space for this country moving forward. Next slide, please. So I don't have time to present all the results, but just wanted to highlight a few things here. If we look at, let's say, the full sample here, if we use MUAC alone, it identified 1.5% of children as being wasted. MUAC-Z identified 8.5% of children, and 𝘏𝘶𝘮𝘢 identified 14.8% of children. Now, if we use 𝘏𝘶𝘮𝘢 as the reference standard, we can see there is a huge underestimation when it comes to MUAC alone, and MUAC-Z improves that a little bit, but still, it doesn't produce the same result as 𝘏𝘶𝘮𝘢 score. So there is an underestimation here when we split by gender, and also for the younger child and the older child, we can see that this trend persists. There are some differences between the subgroups, but overall, I think that that message still stands there. Next slide. Okay. So we also looked at sensitivity, specificity, and agreement and concordant statistics, comparing all these methods. And I wasn't able to present them today, but what we found was that MUAC, so overall MUAC alone failed to diagnose 96% of the children who were actually wasted using 𝘏𝘶𝘮𝘢 score. MUAC and 𝘏𝘶𝘮𝘢 only had slight agreement, where in the agreement analysis, whereas MUAC-Z and 𝘏𝘶𝘮𝘢 score had fair to moderate agreement, but still not strong agreement. And we found that age was an important factor to consider for wasting measurement, where these thresholds did actually differ for the younger child versus the older child. So what is our key message here? Ideally, 𝘏𝘶𝘮𝘢 score should be adopted for community screening as a gold standard for wasting measurement, because we can see the other methodologies are inadequate. However, we know that's not always practical or feasible in a programmatic setting or in the field setting. So perhaps an alternative is to use age-specific MUAC thresholds or MUAC-Z to screen and refer more wasted children for treatment when that is not feasible to be done with 𝘏𝘶𝘮𝘢 score. Next slide. Let me get into the relapse study that we did. This is the last one, and then I will close up, I promise. Next slide, please. What were we aiming to do here? So there was an interest from our partners, and particularly with the government of Somalia, to better understand relapse. Anecdotally, it was reported that many children who were receiving treatment were being discharged and coming back, and they were seeing a lot of repeat cases, but they didn't really know what was the rate of relapse, how many children were actually coming back, and what were some of the things that were driving them or pushing them to come back. And so we wanted to build in a study here where we could try to estimate the rate of relapse and also look at some of the drivers. So that was really the main goal of this sub-study. And so we recruited children. Okay. I see your message, Marina. So we recruited children from OTP sites, so where they were being treated for the cases of severe acute malnutrition. You can see the time period there. And then we applied some inclusion and exclusion criteria, so I won't go through them all, but essentially what we ended up with was a total of 160 children that we were able to follow up for 6 months post-discharge to see whether or not they relapsed to SAM or to MAM, and then what some of the drivers of relapse were. Next slide, please. Here's a data collection timeline. So children were discharged between August 19th, between August and September. And that was the baseline period that we looked at there in 2024. And then we followed them up for 6 months afterwards. So you can see when there was time 1, time 2, time 3. This is essentially on average monthly, but there were some reasons for delays sometimes that happened in those settings. But essentially there was a 6-month on average monthly follow-up for each of the visits. Next slide, please. In terms of our approach to look at relapse, relapse is not a very straightforward thing. It's not a linear thing in terms of like children are treated and then discharged and then can revert back to SAM. They could revert back to MAM. They could revert back to SAM. They could stay, clear of wasting for a while and revert later. And so we wanted to look at all the different scenarios of what would happen when a child is discharged. So we had 3 different cohorts. And so I'll just summarize quickly what they were. We looked at cohort 1, which was children that were normal, so not wasted at discharge, or they were still MAM. And then we follow them up to see if they became SAM or not, so if they deteriorated. And this was evaluated using weight for height Z-score. We also had cohort 3, which was evaluated using weight for height Z-score, which was the completely normal cohort, so cohort that had no wasting at all, and we followed them up to see if they became MAM. And then we had cohort 2, where we used the MUAC-based children, the discharge criteria instead. So children that were normal at discharge, or they had MAM according to MUAC, and then we followed them up for SAM. So these are 3 cohorts, and that's kind of what we've highlighted in the box here. And let me show you what the results look like. Next slide, please. Okay, so we have cohort 1 here, cohort 2, and cohort 3 here. I think let me just highlight what we found in terms of overall relapse rates. We can see that the monthly incidence rates are shown here, and the incidence within the first couple of months is the highest, which is somewhat expected, and also what the literature has shown from other contexts. So really, relapse is highest within the first few months of discharge, and we see that pattern across the cohorts here. With regards to the cumulative rate of relapse, in cohort 1, where we followed up looking for severe acute malnutrition using weight for height Z-score, we found that the relapse rate was about 26%. At month 6. So that is a very high rate. There was another study from Somalia that was done that said that this rate might have been 1%. And certainly this 26% within 6 months is much higher than that 1%. So that is a striking finding for SAM. And then if we did the same analysis using MUAC instead, looking at SAM as an outcome, the cumulative rate of relapse was 13%. So still very high, but not as high as what weight for height Z diagnosed. And that was somewhat expected given what I just showed you in the previous analyses. And then in cohort 3, where we followed up children for MAM, we can see the MAM rates are as high as 50%. So overall, SAM rate of relapse is about 26% in this setting, and relapsing to MAM is about 50%. So huge rates of relapse. Next slide, please. We also did some subgroup analyses, but in the interest of time, I'm just going to skip over these. But there was some variation we saw across age and across, the severity of wasting when the child was enrolled. Next few slides. Next slide. Next slide, please. Okay. And then finally, we looked at relapse risk factors. We had a small sample, and so this was really an exploratory analysis, but we were able to find that the severity of wasting at admission was one of the drivers. So if they were more severely wasted at admission, they had a higher rate of relapse, and that was statistically significant in unadjusted and adjusted models. And so similarly, the length of stay in the OTP was one of the drivers as well, not as big of an effect, but it was statistically significant. So the longer they stayed, the higher they had a chance of relapsing. Next slide, please. And there was a range of other factors we looked at, which again, in this small sample, didn't show up to be statistically significant, but we did find that children being part of the BHA, Bureau for Humanitarian Assistance program, which a lot of the children in these settings were receiving benefits from, which is where the cash was coming from. So children that were part of the cash program were actually had a significantly reduced rate of relapse. both in unadjusted analysis and adjusted analysis. And I'll just say that all the children in this relapse subset study weren't necessarily from the trial. They were from the trial settings, but some of them may have been part of the BHA, the CASH program. Some of them may not have been. So we had a good variation. And that's where we were able to pick this up and see this as one of the factors that contributed to protecting the child from additional wasting, from wasting relapse. Next slide, please. All right, next slide. So in summary, what we found for the main trial results was that Arm 2 CASH plus SBCC was the most effective in reducing wasting prevalence and incidence among children. The qualitative findings helped explain and contextualize the quantitative findings. We found that the Arm 2 was also the most cost-effective compared to Arm 1, and Arm 3 was not cost-effective at all. In fact, Arm 3 increased wasting prevalence and incidence in the child. So it was, completely not cost-effective. The additional cost of the SBCC component of Arm 2 was only $1 per household per month. In terms of drivers, the drivers across arms help explain some of the outcomes we saw in terms of what was actually happening behind the scenes that may have influenced the wasting outcomes. And we found that, for example, Arm 3 did not achieve the same gains in household food security over time, and also a range of other exposures there. And this reinforces the importance of CASH plus SBCC in reducing prevalence and incidence of wasting overall. In terms of concordance, using age-specific MUAC thresholds or MUAC-C may be a practical way to accurately screen and refer more wasted children for treatment when measuring a child's weight for height Z-score is not feasible. And in terms of relapse, children are relapsing, the rates are high. For SAM, it's about 26%. For MAM, it's about 50%. So there's something that needs to be done here to prevent relapse and to support those children from severely deteriorating and ultimately having really adverse outcomes like mortality, and also to avoid a burden on the healthcare system from these repeat visits. Next slide, please. What are some of the next steps for this research? We are now complete with the research. The data collection and analyses have all been done. We are at the stage of disseminating our findings. So there is a countrywide dissemination series of activities that are planned throughout 2025, where we will engage policymakers, donors, and implementers. And within the Somalia context, I think it's coming up in May, we will discuss recommendations and priorities for a policy given the Somalia context. And we hope that these discussions can inform policy and strategy documents on preventing SAM and MAM plus relapse in the setting. And certainly there is an appetite from the government and partners to do this. And we think that the findings from these studies can be used widely beyond the Somalia context to other humanitarian settings that are, there are many settings around the world that are experiencing similar challenges and factors that contributed to acute food shortages or food insecurity that can result in wasting. And so certainly these kind of analyses and results that we have can be applicable to those settings. And, the findings can be used by academia, guideline groups, technical working groups on CASH and social protection, and food security, nutrition clusters, and IPC and other stakeholders as well. Thank you very much for your time. And I see there are some questions that have come through, so I will take some time to answer those in the chat. Marina, back over to you.
Thank you, Nadia. It was indeed a very interesting and dense presentation. I believe the audience is taking time to digest some of these findings that are very interesting, but a lot of information as well. We wanted to take a bit of time also to present what we have done actually in the field, what was our intervention model. And we wanted to really focus on what we think was the key of the success of this project, what worked better in this case compared to other projects in which we didn't have such a successful outcome in terms of prevention of malnutrition. So we're going to have our colleagues from the Somalia country office, Yusuf Mahdi Adan and Isaac Dahira, that are going to walk us through some of these lessons learned from the nutrition and the cash sector. Aden, over to you.
Thank you, Marina. Thank you so much, Marina. This is Aden Mahdi. Just so we are going to at least mention or share our colleagues globally that the best practice that we have come up with how this research, particularly ARM2, was successful when we combined cash plus SBCC that can be prevented or already prevented and reduced the level of prevalence or gun rate based on our experience and the results from the research. Next slide, please. So we our common approach is called resourcing families for better nutrition. This one of our best approaches that Save the Children is mostly adopting and working on it. Save the Children mostly use what's called common approach. Common approach is the best way that we can understand how we tackle the problem for the children. As Save the Children is child rights organization, so each and every child and maybe each and every problem has its own, so it needs some kind of approach that can be solved. So we have more than 14 common approaches. So this is one of the best common approaches that we use. So it's called resourcing families for better nutrition. You can understand how we resource the families for better nutrition. It has components. First of all, we need to deliver cash or voucher for the pregnant lactating woman, the most vulnerable community that has under 5 children or may be pregnant or lactating. Then after, we need to combine social behavior change throughout the process. After the SBC is a large, particularly when it comes to, but now we are focusing on how best can be prevented malnutrition. So cash or voucher plus SBC, as well as our referral linkage if there is additional support is needed to health services or nutrition service delivery. So that there are a lot of components in this. First of all, we do food transfer, micronutrient supplementation, health service strengthening, and also improving clean water or wash system improve. That will have to at least, and again, ANC, what's called family planning. That then our whole purpose is to improve nutritional outcome for mothers and children throughout this process of cash and SPC or social behavior change through the cycle. Next slide, please. So during the process that we were doing in this this research, two particularly, we have combined cash plus SBC. During the SBC, we have done these activities or programs. First of all, the intervention was carried out in 11 sites or 2 regions, Bai and Hiran. We have established 44 mother-to-mother support groups, and also we have done, each group has been consisted 12 mothers, and one of them was lead mother. Lead mother was a trained mother that has been given a training full package of IYCF and social behavior change communication, which has been graduated before this group is established. So that lead mother will support this group is at the community level, and on weekly basis they meet and facilitates the session. So, and beneficiaries of this program has reached was 534 mothers or caregivers who has come from 534 maybe families. So the session was frequently being conducted on weekly basis, which each section will last a minimum 45 minutes at location that they have convenient at the community level. They can come and gather and stay and discuss. related to IYCF and SBC. The technical support has been provided by the trained IYCF promoter that was also a backbone or might be support to the lead mother and observe and oversee how the sessions are going on and taking records and notes. So key messages were being 12 key messages and for over 12 weeks. That is 3 months period. Each and every mother in the support group will have to stay at the program 3 months or 12 weeks. So each week, support groups were being practiced one key message so they can understand well, they can discuss a lot so that they have been understood well. So doubling on M2M or mother support group after the initial 3 months. When they have finished their first 3 months, then every mother also joined another support group to reinforce learning and deepen their understanding as well. To practice more, at least as well as to do more efforts and to facilitate as well sessions so that they have again rejoined another group. So regular supervision, mother's attendance were monitored by the Save the Children program team to ensure they fully attend of all sessions. Because otherwise, if they miss sometimes, they might miss some key messages. So we will have been reinforcing and maybe all caregivers to attend regularly because it is the sessions is being conducted at community level at their own convenient time. Next slide, please. So then after we have done some kind of to strengthen the IYCF practice, we have this kind of strategy, some kind of integrated strategy. First of all, we increase the awareness. After we increase the awareness, attitude has been gradually started to change. We heightened awareness of the proper nutrition and its health impact through strategic messaging and education. IYCF sessions and SBCC and everything related to wash, hygiene, nutrition, and health messages. So that after attitude, positive shift in attitude toward optimal IYCF practice has been observed. Health seeking behavior, the same improved, and health eating by challenging cultural beliefs and reshaping social norms also improve it. So when they are being given these sessions, we encourage them that they use locally available foods rather than imported foods. So they have been given how they are being prepared, the balanced, locally available dietary, so that after that they were challenging cultural beliefs of which they were sometimes using single food. Now they have adapted different kinds of foods with that is grown at home. So that kind awareness and attitude. After that, access and action. Then after that it improved access when we have raised awareness and gradually attitude is starting to change. Then access started at the same time after action has been converted. So improve access to nutrition, age appropriate, locally available and affordable foods has been adapted through cash support. They have the cash. At the same time, they have been given the sessions and awareness and messages. So they have jointly adapted both cash plus the SBC, and so they have done practice. So mothers are empowered with the knowledge, creative recipe ideas, and practically they done food preparation skills. Then the strategic approach was, first of all, we have done the community mobilization. We have started the leaders, influential leaders, sheikhs, holy Quran teachers. Those are most influences because sometimes even they tell this information through Jum'ah prayers because it is a must. IYCF is must. Breastfeeding is must. our religion is obligatory, saying 2 years should be breastfed with each and every mother, so that the community mobilization through leaders influences, they give us maybe support when it comes to context specific SBCC to promote feeding. So that was a very big opportunity. Also, hygiene and healthcare practices, caregivers and health workers training also give us another important might be chance that we have started to change to communities adaptation, formal cultural negative challenges, so that when we integrate health and social services and policy, so that will at least give us policy support for sustainable scale up. So now it is good for us to at least learn that if we do multiple integration programs rather than standalone programs, so all the programs will support each other and complement each other. Next slide, please. During our SBCC activities, our model that we were using is this was maybe socio-ecological model, which you see child and mother at the center, at the same time home visit with the family, at the same time community level of cooking demonstration, mother to mother support group, special events, fathers and influential and grandfather and grandmother and maybe traditional birth attendants influencing. So all these are supporting. Then after that, we at least encourage it or maybe increase the advocacy with the local authority and maybe the decision makers, fathers, and everyone related to. So this is the methodology or maybe what we have, the approach that we have used. So activities were maybe home visit, first of all, when particularly those mothers with 1,000 days families, mothers with less than up to 2 years children, those who have mother to mother support groups, we have been, and father also, father to father support groups, we were establishing one session per week for 4 sessions per month. That was the approach that we have done. 12 sessions throughout the program. During the program, 3 months each and every support group. Cooking demonstration. We were also given sometimes cooking demonstration, how they can add balance, how can they prepare balanced diet and with locally available food. And also we have been doing mobilization of local authorities and the health system as well, so, to at least support and strengthen this system. And also mobilization of community elders, as I already mentioned, community leaders, opinion leaders, to take part SBC, and which is actually has happened. Sheikhs and maybe Holy Quran teachers were sometimes were doing during Friday breach at the mosque at the gathering. So that is breastfeeding is compulsory the first 2 years of age, as the Holy Quran ordering as Allah. So mobilization and awareness raising through mobile messaging, through when mobile money is being transferred. Our brother Dahir will talk about it, that mobile money, when it's being transferred, also some kind of messaging, very important messages related to SBCC were being delivered through their mobile. So they were having time to listen and maybe adapt, and sometimes listen and listen and listen more and more. So I will hand over to Dahir to next slide. I will stop here. Over to Dahir. This is maybe support groups and the photos of fathers and mothers. The next, what was the next slide, Marina?
Yeah, I think we can go to the next couple of slides. Those are
So
some photos from our
the practical
programs.
sessions.
Yeah.
Yeah.
Yeah. Exactly. Thanks.
Right.
Over to you.
Dahir, over Dahir. Welcome to Dahir, Isaac. Thank you so much.
Thank you very much, Adam. Thank you very much, Marina. Good afternoon, good morning, ladies and gentlemen. I will take you through the cash delivery and the modality we use in Somalia. This is because, as my previous colleagues mentioned, having such a cash plus SPCC approach needs to have an effective cash delivery, cash programming in the countries. So for Save the Children, what we have been doing for the last 2 decades actually enabled us that we build trust and understanding in the context with the communities on the ways of work and how we do cash programming in Somalia. Save the Children is one of the key actors and a member of one of the key consortiums of cash programming in Somalia, which is the Somali Cash Consortium. Based on the interactions and the presence we have in the country, which is around 14 offices across Somalia, it enabled us actually to build this kind of trust with the communities, which actually helped us to develop a programming with the communities, which they are familiar with, which actually helps us to understand them smooth and acceptable cash transferring. Save the Children in terms of operational capacity actually has a standard operating procedures for cash programming. It regularly does feasibility and risk assessments, including delivery mechanism assessments, capacitating its staff at field level and at technical level so that they are actually at par in engaging with the communities and actually delivering an effective cash programming. We have an active framework agreements and partnerships with key financial service providers, including mobile money operators across Somalia and Somaliland. So this kind of actually operational capacity, with the help of the coordination that we have with the partners across the platforms like Somali Cash Working Group and the clusters, most importantly the food security cluster, protection, health and water and the like, helps us actually to develop a capacity and an engagement plan with the communities that we serve so that we deliver an effective plan. That kind of engagement we have also helped Save the Children to have a deep understanding of the context and the culture and the needs on the ground, which actually helps us to shape the design and the implementation of our cash programming across the country that we are implementing. It not only helps to have actually implement a smoother cash programming, but also it helps to have a constant engagement with the community so that they also inform our programming and how it is safe and accessible through our accessible feedback redressal mechanisms that we have. Next slide, please. The modality we use at the delivery mechanism we use, which is actually a mobile money system, actually ensured that we disperse the funds very rapidly when actually the people need most, and at scale if the actually program is actually scale it up, and so flexibly so that the beneficiaries that we are providing cash with can directly transact the payment, so that literally they don't need to cash out the cash programming from an agent or for financial service provider agent, but they can directly transact in some of the contexts where even we don't have such, most of the people actually directly transact the cash with the same currency that actually the donor give us all, and we deliver it to the community so they can buy and pay purchases directly. But in some contexts like Somaliland, where people actually use to transact with Somaliland shilling, they can also have the ability to transact or exchange the dollar with Somaliland shilling within their mobile wallets. So that kind of financial services available in the context also helped us to deliver an effective cash program. The market monitoring that we do, or the other partners, like the Joint Market Monitoring Initiative, that does actually help us also to monitor the prices of the commodities, particularly the nutritious food that we are actually intending to provide with the child and the mother that we are supporting, so that we measure the adequacy of the transfer value that we are providing. One of the examples is how we came up with the $35 that we are actually giving the maternal child, which actually based on the prices of the key commodities identified for the mother and child as a nutritious food necessary for the growth and the nutrition. One of the key aspects is in terms of effectiveness is the coordination that we have within the Save the Children, particularly the teams that are implementing the cash and the nutrition activities. So they actually optimize their cost efficiency by sharing the staff, sharing the logistical arrangements, so that we minimize the cost that we deliver a combined or integrated services, which is cash plus the messaging that we are supposed to deliver. One of the core aspects of our programming, which I can say actually is the most important one, is the centricity of the beneficiary in our programming. So from the transparent communication which we deliver to the communities from the start, like information sharing of the brochure, giving them platforms to contact us and inform us if they are actually feeling safe, or our services are acceptable and accessible all and on. From that communication, initial communication, to the community mobilization that we are doing, to the decision making and the responsive and accessible feedback mechanisms we have, actually helps us that the Save the Children programming, the team that delivering the services, and the communities that we are serving, both the beneficiaries who are receiving and non-beneficiaries who are supporting, like the key stakeholders at district or village level community structures that we work with, help us actually to deliver a supportive and effective cash transfer programming that are integrated to our nutrition activities. Thank you very much. That is all I can say. And over to you, Marina.
Thanks a lot, 𝘏𝘶𝘮𝘢𝘳𝘪𝘢𝘯𝘨. Thanks to the presenters. I think we are all very interested and excited about what we are hearing about from this project. And there are so many questions and answers. We've tried to answer to most of them, but we are running slightly late. So I would encourage you to continue to post your questions in the Q&A window. And I think we can very quickly launch the following poll questions, Miriam. I'm going to hand over to you, Shelly.
All right, thanks, Marina, and thanks to all of our presenters. As Marina mentioned, we are running a little late on time, so we won't have the full opportunity to do some live Q&A. But I did just want to highlight a few things as you all are looking at the poll questions here. I think that just to summarize some of the main things that I'm seeing coming out of the Q&A, I think that there is absolutely room to discuss more in terms of the findings in the relationships that we saw between the mother's results and the child's results. So I think that kind of underlining that and making sure that that comes out very clearly in future conversations and discussions on the work that we did here. I think that there's also a lot of interest clearly in the actual implementation of the SBCC. So I think that there's a lot of good chat in the Q&A and discussions there that need to be addressed and further explained and articulated. And then I think that the other big thing that requires a bit more discussion and consideration are just what exactly we're then suggesting for the arm 3 that received the additional top up. Is there a certain threshold that we're considering? What would that threshold be? What additional research questions might relate to what that top up amount could see in terms of benefits? So with that, I see that we have some good poll responses here to our question on what do you think now can cash be effective to preventing malnutrition? And really we wanted to gauge your understanding or your view of now seeing the results. So we have fewer participants that responded to this question, and I think that we're seeing a similar splits, but I wonder if we can launch the next poll question and see more specifics as to how you would use the results of this research in your setting. So this is something that we're very keen to find out from all of the participants. So how would you use these results? And please feel free to select multiple options here. All right, and then if we can see the results for that question. Great. Okay, so we see some even splits throughout. I think the most participants are suggesting that they would use the results to really improve program design, to strengthen implementation, and then to integrate with other interventions. So I think that this is really key. I would say that this group, all of us, learned a lot about just how to consider and improve program design and overall implement some various strategies to improve the cash for nutrition interventions. So let me close this out. And I think we can go to the next slide. Great. And Marina, back over to you for the final sessions here.
Thank you. So I'm gonna now have a quick discussion with some of the stakeholders that have been involved somehow in this project to really hear from them how they think they're going to use the findings of this research for future programming and policies on CVA for nutrition. And I think I'm going to ask you to be very short and use 2 or 3 minutes each. And we are going to start with 𝘏𝘶𝘮𝘀𝘀𝘀𝘀, is the head of Nutrition, Health and WASH from the Somalia country office. Next slide, please. And Omer, over to you.
Good afternoon and good morning. I'm 𝘏𝘶𝘮𝘀𝘀𝘀𝘀, Head of Health, Nutrition and WASH Program for Save the Children in Somalia. Next slide. Yeah, as presented, malnutrition in Somalia is one of the public health problems, especially when we compare in sub-Saharan Africa. Is one of the countries with the highest rate of acute malnutrition. This year, in the first quarter, the estimation for projected children that are going to experience acute malnutrition was around 1.7. Now it's increased to 1.8. Of that, half of them with severe acute malnutrition. So some of the key drivers in Somalia: poor rainfall, erratic rain patterns, frequent drought, flooding, and due to climate change, conflict and insecurity that cause frequent displacement is one of the main causes, including a high food price, food insecurity, high disease burden, and the closure of health and nutrition services, especially this year, due to decreased significant reduction of funding. Significant facilities that was providing health and nutrition service for maternal children are now closed or at risk of being closed and limited access to safe drinking water and sanitation, hygiene, poor IYCF practices, socioeconomic factors, including poverty, limited income opportunity, gender inequality. Yeah, these are the key drivers of acute malnutrition in Somalia, including the relapse, of course. Next. So from the research, yeah, we actually, as 𝘏𝘶𝘮𝘢𝘯𝘪 said, or Adam said, we learned a lot from this research. As Save the Children, we have two common approaches, specifically when it comes to IYCF and cash. This is what we call resourcing family for better nutrition and nourishing the youngest, which is more focusing on SPCC related with IYCF programming. So this actually, this evidence has given us, you know, a more understanding about the effectiveness or the big opportunity that we can really leverage when it comes to cash program in terms of intervening and preventing malnutrition in Somalia. So yes, cash can be a big opportunity, but we learned that also cash alone by itself is not sufficient. So we need to have, you know, a SPCC strategy that actually addresses the key behavior or practice that the mothers or caregivers needs in terms of improving the nutritional status of the children. So actually the cost and even the technical requirement for the integration of the SPCC to the cash is not really that much difficult, and we have actually tried to integrate what we're already doing separately when it comes to nutrition related with IYCF programming and other key messages that we think that improve the malnutrition rate in Somalia. What we have tried, as 𝘏𝘶𝘮𝘢𝘯𝘪 mentioned, is how we can really leverage the cash program and the coordination between the cash team and the nutrition team, and the design of the key messages and the approaches, which we already doing great, of course, when it comes to the IYCF program. But the IYCF by itself is not sufficient in terms of changing, because mothers who have a better understanding about the behavior or the dietary diversities that they should feed their children, they need, of course, sometimes cash to access what they have learned from the IYCF counselors or from the community counselors. So integrating SPCC to the cash is really make the program more effective and cost efficient, and the impact was huge. And cash by itself, when it's integrated to SPCC, can be used in terms of prevention or stabilizing the deterioration even in high burden humanitarian contexts. So additionally, the research finding has shown us that integrated programming is more protective in terms of protecting children from acute malnutrition. So in Somalia, where especially in high burden area, I think as much as possible, we need to really design the programs in more integrated way, because this is the drivers of acute malnutrition is multiple factors. So multi-sectoral approach is the key in terms of prevention and protecting children. Yes, cash actually is run by the FSL team in Save the Children, of course. In other organizations also, an SPCC or the IYCF is the nutrition team. So we need to have, you know, kinds of modality or implementation guideline that can actually guide the team and the program team in terms of how best they can integrate cash with SPCC so that it can be more effective in terms of addressing malnutrition rate. And yes, we often overlook, of course, the cash, the impact of cash in terms of improving malnutrition. So it need to be considered in multi-sectoral nutrition strategies. In future, I think future cash program shouldn't be only a money transfer, but it should be, you know, intentionally integrated to SPCC to address the underlying cause of malnutrition, especially around feeding, care, and hygiene, and sanitation practice and health-seeking behavior. The research also has indicated really high relapse rate, which is very concerning. And as Save the Children, yes, the sample size was small, but now we are doing a bigger kinds of relapse study across different livelihood zones, and the objective is to understand more about the pattern and the rate and some of the drivers, and so that we can really use evidence that we are generating from this relapse study to guide in the future. Because if the malnutrition, with this high malnutrition rate and with a high relapse rate, it's actually impacting the effectiveness of our current CMAM program. And it's something that really all partners, including donors, need to consider, the government to consider in terms of tackling the high relapse rate in Somalia. And of course, hopefully by this year, next year, we will have some kinds of evidence and understanding on the pattern of the relapse rate and how we can really tackle this big challenge. Yeah, thank you, Marina. Over to you.
Thank you so much, Meftu. And I am sorry, I'll have to ask to the next speakers to really take a couple of minutes each because we are running out of time. So Dr. Ali from the nutrition program of the Federal Ministry of Health of Somalia. Thanks for joining us. Over to you.
Thank you very much, Marina. I would like to thank, good morning and good afternoon, everyone. I would like to thank colleagues. My name is Dr. Osama Abdi Ali. I am the Nutrition Program Manager of the Federal Ministry of Health, Somalia. The Ministry of Health in Somalia has been part and parcel of this research process. I would like to thank Save the Children Country Office and as well the global team. I also want to thank the university, the Johns Hopkins University, and the other team who have participated in this research. As everyone has mentioned, the CASH nutrition project, specifically the CASH plus intervention, has been tested in Somalia, and it carries significant implications for further programming and policies aimed at adapting malnutrition in a humanitarian context. In relation to that, this research will give us a key highlight on the way to the success of CASH plus programs in improving nutrition outcome. This suggests that cash-based interventions can be an effective alternative or complement to the traditional in-kind assistance. This allows beneficiaries to have more autonomy as well in purchasing the food and also the services that they may need. Next slide. Now, because this research has been conducted in the country and it's an evidence-based policy development, the Ministry of Health is now working on several policies, including the IMAM guideline, the integrated management of acute malnutrition, and this will help us. This will encourage us to adapt this evidence-based in our policies and also in the upcoming the nutrition strategy that will be formulated by the Ministry of Health late this year. As well, this research supports a shift from the traditional food aid models to more sustainable, locally driven solutions. And the government may start to develop national strategies that integrate cash-based transfers alongside other nutrition interventions to improve the health outcomes of the population, as my colleague had mentioned. Yes, next slide, please. Thank you very much. Back to Marina.
Thanks, and I'm going to hand over to our Global Head of CVA, Nick Anderson from Save the Children.
Thank you, Marina. I will try to make this quick. I think from our perspective, some of the key outputs and the outcomes that we've learned from this, in addition to, I think, some of the process aspects around working with and collaborating from the beginning with the Ministries of Health and local partners to ensure we have proper access into the communities for what is research implementation, is also the collaboration with external academic partners like JHU. They bring a rigor to the process, to the methodologies that sometimes I think we don't have the resources and NGOs to implement. And there's been a lot of success, but there's also been challenges in bridging the divide between the implementation requirements, the timeframes, the context of our humanitarian programs, and the rigor of academic learning. So I think there's a lot we can learn from this and replicate elsewhere. And then one of the key takeaways from this is there's a lot of opportunity remaining in terms of learning about what works and what doesn't work, what are the drivers of some of these results. I'm not going to go into all of the bullet points, but there's a lot of questions around the frequency and length of cash transfers. I think it's intuitive to think that longer duration means better results for delivering cash, but at the same time, we know that when there are financial pressures internally and for the donors, the first thing we'll do is cut the length of the transfer and then cut the size of the transfer. So further exploration, or what are the changes that we see at 6, 9, 12, even longer months is critical. There's a lot of questions also around intra-household dynamics and what are the impacts on cash. I think there's been some interesting findings, and that the cash top-up for nutrition didn't have the results I think one would have expected. But at the same time, we need to do more about understanding who's making the decision-making in that household, incorporating more gender analysis, but also expenditure patterns and what decisions are being made around when. There's an interesting question around whether knowing that you have transfers coming for a certain period of time leads to different behaviors in the short term, in the medium term, in the long term. And I think there's still learning that we can do around the SBCC component. I think somebody had asked the question around, can you do a one-off SBCC and achieve results? And that's something that I don't think we know, and something we would like to explore. And then one last point, if we have any donors remaining on this call and other people interested in these approaches, I think one of the main challenges we've had is financing implementation along with research. I think we all have large scale humanitarian programs. Sometimes we find research funding. It's really hard to marry the two, to find the implementation approach that is new and innovative that you want to test, because if you're testing something, donors are not going to fund it. At the same time, you rarely find research funding to allow for implementation. And that is really a key thing that we continue to explore, and would go a long way towards allowing us to implement proper research in these contexts, and then take them to the next step, which is the priority of all this, and that is deciding how they can be incorporated into future programming, because all of this that we do is operational research with the intention of impacting future programming and the results that we are delivering in these communities. I think that's it. Thank you.
Thanks, Nick. And I'm going to hand now over to Kate Golden, one other member of the Cash and Voucher Nutrition Working Group from 𝘏𝘶𝘮𝘀𝘀, the other organization that is co-chairing the group. Over to you, Kate, for your final words.
Thanks, Marina. If anybody's still out there, I'll try to do it in 1 minute without repeating. So I'm a part of the global CVA for Nutrition Working Group, but Concern also works in Somalia, and I think some of my colleagues were there. We also lead the Somalia Cash Consortium. Alessandro Bini is there, I think, or he was in the chat. So obviously this highlights really the complex factors driving child wasting, and I think we know that, and we saw p-values in different parts of the results that we've gone through this for Concern as well, trying to piece that together, but it really highlights that many of those factors are context dependent and season dependent. And I have learned over the years that the seasonality in this part of the world is very complex. And also that CVA can help address some, but not all of these factors. And I think if you can see on the right side of the screen, some ideas about what we as the global CVA for Nutrition Working Group and the nutrition sector need to work on. I think one of them is some simple tools to analyze the drivers in each context. We do have some quite comprehensive tools, but really to zero in on what are some of the barriers that could be addressed with a bit of cash. It also reinforces that CVA on its own rarely improves nutrition. We need the plus, and in this case, the SBCC was the plus in the Somalia example. And we interestingly did a similar study with UCL in 2019, and the research was called Cash for Improved Nutrition in Somalia. And we had slightly different findings. So we found that cash plus some soft-ish conditionality around registering your child at a health center had no impact on nutrition status, but it did have very clear impact on vaccination coverage, which we had identified as an underlying issue for malnutrition in our context. And this might be due to study staff and other community health workers kind of promoting people, reminding people that they had to go get that health card and get registered at the health center before they would get their cash. And we also found, in really in contrast to what this study found, is that cash plus that same soft conditionality plus social behavior change via electronic messaging on a phone in kind of a soap opera format had no additional impact on nutritional status. The last 2 points are really nutrition focused. I think most of what we saw today is probably CVA maybe addressing some of the more food route aspects. I think other people spend their cash however they like, but we also feel that there's a real need to document and try to generate more learning around how CVA could be used to support access to treatment services and other health services. Many actors are experimenting with this non-food route to improve nutrition. And we really need to kind of bring it together and figure out what people are doing and some interim guidance. And my last observation is just that the age-based MUAC could really offer a practical solution to this big weight for height Z versus MUAC dilemma. And the barrier, obviously, as I think was mentioned, is that we can't drag height boards and scales to remote areas. So if we could have something that is practical, we would love to see it, but I think there needs to be more research on the feasibility. I've seen the little bands and it's more complex. So can, sort of low literacy community health workers actually use it would be a question for further research. Over. Thanks very much.
Everyone, we are really running out of time, but let me just wrap up the next steps and closing. Thanks to everyone. All the resources that you have seen today will be shared with you on the GNC webpage. Next slide, please. I just wanted to remind you that the GNC is really here to support you in case you have any technical questions or any need for support. There are different ways that you can ask, and like they are presented here in this slide. So don't hesitate to reach out to the GNC in case you would like us to support you on CVA or the other groups, the other core groups on the different thematic. You can use this QR code to learn more on what we do. Next slide, please. Thank you so much. This is who we are. You find more information on the GNC webpage. And remember, you can use this function that was indicated with the green flash to request support. Next slide, please. And thanks, we are going to launch a post-webinar survey. We're going to take a very, very little time. It would be great if you can participate. Thanks to everyone. Thanks to the GNC. Thanks to Johns Hopkins University, the Somalia colleagues. Thanks to all the invitees to stay with us for this time. And looking forward to the next webinar.